Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of 52 Weeks of Diabetes Essential with Dr. Sanjay Kalra. And as holy month of Ramadan is around the corner, we have planned three lecture series especially for Ramadan, as new development in diabetes can be helpful to your diabetes patient following Ramadan holy month. Last week was the first lecture on the topic Ramadan fasting and health. In case if you have missed it, then you can see in our archives. And today is the second lecture on the topic risk stratification and pre-Ramadan counseling. Today's session is brought to you by your zero calorie hydration partner, Enerzal Zero. Now, I would like to welcome our host, Dr. Sanjay Kalra, sir, President elect, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and good evening, everybody. Like Ankur said, the holy month of Ramzan is approaching. And in Diabetes Essentials, we thought that it was essential for all of us to know how to manage this holy fast. Last week, we had Dr. Shaila Sheikh from Mumbai speaking to us about Ramzan fasting and health. Today, we have with us Dr. Hamid Ashraf. Warm welcome, Dr. Hamid. Dr. Hamid is Professor of Endocrinology, Head of Department at Aligarh Muslim University, one of the most dynamic endocrinologists in the country. Dr. Hamid, warm welcome to the Diabetes Essentials family.
Good evening, sir. Thank you very much for the opportunity and for those encouraging and refreshing words.
We thank you for joining us. And Diabetes Essentials is a program which we conduct for doctors across the country, those in primary care, also those in specialty care. And all of us are united by one thing, that is, we have this need, we have this urge, we have this feeling that we want to make India the diabetes care capital of the world. We want to make sure that diabetes care reaches the primary level, the primary care level throughout our country. So with this, Dr. Ashraf, I'd like to welcome you. Good evening coming for you from Karnataka, from Dr. Gauri Shankar Dharmaraj. And would you like to teach us more about Ramzan and how to manage diabetes during Ramzan?
Hello.
Yes. Slides not visible as of now.
Okay, slides I have already shared, I think.
Mhm.
Just a minute. Where is it? Present. Share screen. Share screen.
Yes.
Entire screen. Just a minute.
Now
The
they
slides
are.
are visible now?
Yes. Perfect. Perfect. Pre-Ramadan assessment.
Yeah, okay. A very good evening to all of you, and I'm really thankful for the whole team for giving me this opportunity. And I'm thankful to the chairperson, Dr. Sanjay Kalla sir, for the nice and kind introduction. So today we are going to have some amount of, you can say, discussion regarding the pre-Ramzan assessment. And this is the outline of my presentation. So we are going to discuss the fasting during Ramadan, what is pre-Ramadan assessment, and how to assess these through a flow chart, and who are the targets of this Ramadan focus education, and what should be the key component of Ramadan focus educational program, and what are the positive impacts of Ramadan focus education, and finally the take home points. So we know that fasting during Ramadan is a type of intermittent fasting, and fasting is definitely one of the things which we all are very well versed, because our country is a very livid and different kind of cultures, religions, they are living together. And we have seen that in every culture, in every religion, there is some form of fasting which is there. So we are basically well versed with the kind of fast in different kind of religions, and different kind of people are keeping fast. So and the Ramzan fast is slightly different from the many other types of fast, because in that situation, not only the food is not taken, but also the fluids are restricted. So during the month of Ramadan, it can be very change in the meal schedule and fluid intake, sleep pattern, and that can also lead to, because from daytime eaters, most of the people, they become eaters during nighttime, nocturnal eaters. So there is change in the circadian rhythm, there is change in the hormonal levels, there is change in the pattern of different hormone secretion like cortisol and growth hormone. So in people with diabetes, it includes because patient with diabetes, they have insulin resistance, they have increased counter-regulatory hormone, that is glucagon, and there is shift in the cortisol rhythm, and a reduction in the morning adiponectin levels, and they have also increased morning leptin levels, reduction in morning and evening growth hormone levels. So we can see that this is CGM finding in people with diabetes during Ramzan. So here you can see that before Ramzan, there was a very less amount of glycemic variability throughout the day. But during Ramzan, here you can see that the blood glucose starts going down after the, you can say, afternoon, and it is at the nari level during the just before the iftar, and after that it rapidly shoots up and goes up, and it remains like that till the suhoor, and after that during late morning it begins to come down. So why it is important to assess patient during pre-Ramzan period? Because it's very important to tell the patient how to basically make changes which are required in patients of diabetes, so that they can fast in a safe manner, and they can have some amount of benefit in that. So it should ideally start 6 to 8 weeks before the start of Ramadan, and the healthcare providers will be able to obtain a detailed medical history and perform a risk assessment. Along with that, this also gives an opportunity to make the changes which is required for safe fasting, because if someone is coming with a history of recurrent hypoglycemia, or someone is having very severe hyperglycemia, so we cannot correct those things in a very small period of time. So we need at least 6 to 8 weeks in an ideal condition, where we need to assess the patient, we need to see the patient, and we need to identify the risk which can be leading to complications during Ramadan, and we need to fix those kind of things. So, and this includes the advice on whether the fasting is safe, because we will see how to assess the risk, what is the, how to calculate that score for fasting, assessing the fasting risk, and what are the strategies for dose modification and treatment regimen adjustment. And there should be a provision of Ramadan focused education, because this is the time where the patient is very much, you can say, receptive. Most of the time they may not listen to you in our OPD, but during pre-Ramzan period, it gives us an opportunity, because patient is many times they are quite receptive. So if we want to make some kind of change, and this also provides an opportunity, and because weight loss, we know that it is a very important and you can say very useful kind of thing to happen in a patient of diabetes, specifically those who are obese. So Ramadan provides an opportunity where if we give focused education and proper education, then achievement of weight loss is quite easy during Ramadan. So following this, the individual who decides that fast, they will need to adhere the guidance on the management of their diabetes. And after the Ramadan ends, and it is advised that we should also perform a post-Ramadan follow-up, and we should see what are the problems that the patient has faced during Ramadan, and what are the things which has happened to them. If their weight loss has been achieved, then we should educate the patient that now you have achieved some amount of weight loss. So it's better that you should, if you can continue on this weight only, if you don't regain the amount of weight which you have lost during Ramadan, it will be very good for your, you can say, in future you will be reap benefits from this weight loss which has happened during Ramadan. So, and this process must be undertaken at each Ramzan. A successful fasting one year does not guarantee success next year. And this, the, you can say, the experience from the current year gain will be immensely helpful while we are dealing patient the next year during Ramzan. So this is the assessment flow chart. What are the things which we need to assess? We first need to quantify the risk of fasting during Ramzan, and we need to see what kind of SMBG the patient needs, and we need to explain the patient when to break fast, when to exercise, and the meal planning and the fluids. They are also very important. What kind of fluids should the patient take, and what kind of meal patient should take at iftar, and what kind of meal patient should take at suhoor, and in between, if the patient wants some kind of snack, what should be there. And this Ramzan nutrition plan is there on the site of this IDF, where anyone can go there and they can make their chart by using different filling the different data about height and weight. And if the patient want to lose weight, or patient wants to continue the same amount of weight, they will give a very good kind of chart for different days. So that can be done, which is available free of cost online on the site of website of IDF. So, and all individuals at the pre-Ramadan assessment at the 6 to 8 weeks, we should need to take a detailed medical history, and what are the aspect of diabetes and ability to self-manage, what is the patient understanding of his disease and complications and all other things. And the presence of comorbidities form an important part of risk assessment, because if in presence of comorbidities, things are quite complex, and so we need to identify the comorbidities, whether it's under control, it's uncontrolled, compensated or uncompensated. In that situation, we need to make our assessment and tell the patient about their risk. And the individual's prior experience in managing diabetes during Ramzan, which we have discussed in the last slide. And we also had to look at the individual's ability to self-manage diabetes, because the individual's ability and the ability of the caregivers, which is there with the patient, it is also very important, because they need some amount of, you can say, good guidance how to keep fast, specifically in those patients where the risk is high. So if we do that, after that we can stratify the risk as low, moderate, and high. And frequency of SMBG needs to be guided by the risk stratification. For example, if the patient is in high risk and there is a patient is, for example, we will see who are the high risk. In that situation, patient may need quite frequent monitoring. And if the patient is on those kind of drugs where the chances of hypoglycemia is less, patient is well controlled, comorbid conditions are not there, then we may not need to do so much of monitoring until the patient is having symptoms. So, we should emphasize on these things, that patient should break their fast if their blood sugar is too low or if it is too high. For example, if it is less than 70, then in that situation, patient should break their fast. And if it is more than 300 milligram per deciliter, in that situation also, patient should break their fast. And we can very easily explain the patient that कि भाई अगर आपने एक दिन रोज़ा नहीं तोड़ा और एक दिन रोज़ा नहीं खोला इसके चक्कर में, तो मे बी कि आपके साथ कोई कॉम्प्लिकेशंस हो सकती हैं, फिर आपको 3-4 दिन हॉस्पिटल में लग जाएंगे, और फिर आपकी नमाजें भी छूट जाएंगी, आपके घर वालों की परेशानी हो जाएगी. तो somehow we need to we can say assure our patient that this is for your benefit. If you are having problems, then you should break fast, because in that situation your problems will be minimal, and you can continue your fast from next day, or after visiting your doctors, you can share your problem and you can get your advice, and you can, after that, you can continue with your fast. So risk quantification, as we have already discussed, it should be done at least 6 to 8 weeks. And what are the factors that contribute to the risk factors, which we can see in this slide. It appears quite lengthy and busy, but it's not. It's quite easy to do, because what it includes diabetes type and duration, whether duration is more than 10 or less than, then the presence of hypoglycemia, what is the level of glycemic control, what are the types of treatment, and what is the patient ability to take care in form of self-monitoring of blood glucose, any acute complications, this vascular complications or comorbidities, renal complications, patients, those who are pregnant or not in females, frailty and cognitive functions, physical labor, and previous Ramadan experience, as we have already discussed, and fasting location, that is the duration of fasting, it is going more than 15-16 hours, definitely the risk is slightly high. So in that situation, if we calculate a risk, and if the score is between 0 to 3, then it means that patient is low risk, and between 3.5 to 6, then this is moderate risk, and more than 6 is high risk. So in high risk patient, we tell that medically you are unfit for fasting, But many times, even those patients who are at high risk, they insist on fasting. In that situation, we need to give them you can say, good kind of counseling. And even if they are persisting that we will keep the fast, in that situation we should explain the signs and symptoms of hypoglycemia and hyperglycemia. And the thing which we have discussed previously, that when to break the fast is very important in this situation. So we can try that. So who are the targets of Ramzan focus education? So you can, as we are having at this moment, the healthcare professionals, because they are one of the most important pillars in providing the management. So at first, the healthcare provider, they should be aware that if the patient is insisting on fast, and when to allow them to fast, when to tell them that we should break your fast, and whom to tell that you should not keep fast because it can lead to bodily harm. Because the knowledge of the peoples who are exempted from keeping fast is definitely, it is there in the Quran. So no one can deny that fact, that if anyone who is traveling, anyone who is sick, the pregnant women, lactating women, in that situation, there are exemptions which can be used if the patient is having problem. And people with diabetes, definitely the individuals themselves and their family and their caregivers, because Ramzan is a time where the whole family, because if they are not taking meal together most of the time during the year, but during Ramzan everyone is there at the dining table at the time of breaking the fast, and all of them take suhoor together. So family and caregivers, they also need to be explained regarding the sign and symptoms of hypoglycemia, what are the things which needs to be taken during diet during Ramzan. For example, what should be taken at the iftar time, what should be taken at the suhoor time, and all those kind of things need to be discussed with family members also. And general public is also very important, because religious and community leaders, for example, the imams of the mosque, the mufti, and all those kind of things, we need to involve them. So a general consensus can be arrived, and general you can say the education level and the information level can be increased, because misinformation is so much there in society for everything. So we need to explain a few things which should be clear to all the patient, that for example, if we are doing the self-monitoring of blood glucose, that does not invalidate the fast. If someone is taking insulin just prior to the, you can say, this iftar, that is also not going to invalidate the fast. So these things are very important. We should discuss the patient, and we should encourage patient to do more amount of monitoring, and so that fasting can be safely done. So these are the key components of Ramadan focused educational programs, which we should do if we are taking care of people with diabetes who are going to keep fast during Ramadan. So first is that risk quantification and exemption, and removing the misconceptions like we have talked, and the blood glucose monitoring, fluid and dietary advices, physical activity and exercise advices, and adjustment of medication is also very important, because most of the medication, they needs adjustment during Ramzan, specifically if the patient is taking insulin and sulfonylureas, they definitely needs an adjustment. Otherwise, patient is going to have problems. And when to break the fast, which we have discussed, in any event of hypo or hyperglycemia, if the patient is not feeling well, in that situation, definitely patient need to break the fast. And the recognition of sign and symptoms of hypoglycemia and hyperglycemia, and need for checking blood glucose at the time of these kind of symptoms. For example, there is excessive weakness, excessive thirst, or there is drowsiness, tremors, sweating, palpitations. If these things are there, then definitely patient needs to check their blood glucose, and to see if the blood glucose is controlled or not. So this is a very important misconception which needs to be removed from our patient, that the doing self-monitoring blood glucose is going to invalidate the fast, that pricking your skin to get the drop of blood is going to invalidate the fast. This is not correct. So one can easily do, there is no problem in doing that. And it is very important if someone wants to keep fast, and which should be achieved safely, specifically in those patients where the patient is taking those kind of medication, where hypoglycemia is essentially an important threat which can be there. So checking blood glucose gives us some amount of confidence that okay, we are going good. so we can keep the fast. And if we are checking blood glucose after iftar, so we can see that our blood glucose is not shooting up, that our iftar meal is also doing good. So this is a 7-point blood glucose which can be done in patients of diabetes mellitus during Ramzan. But this intensive monitoring is not required in most of the patients if they are not taking secretagogues. So patient can, and if we have to do one blood glucose, then it should be before you can say iftar, because that is the time when the hypoglycemia is more prominent. And after that, after iftar, patient should check blood glucose, because that also gives us an idea what kind of meal the patient is taking, and if the blood sugar is going so very high, then it can lead to problem. So, and after that, it can be done during morning, midday, mid-afternoon. So that kind of things can be done. And also, it's very important to explain that at any time when the patient is not feeling well, in that situation, blood glucose should be the first thing to do in a patient of diabetes who is fasting. So we need to provide you can say counseling regarding food and dietary advice. This is not so much different from other days. Only thing is that we need to ensure that meals are well balanced, and around 50%, and in our setting you can say around up to 55 to 60% patient can take carbohydrates, 20 to 30% protein, and less than 35% should be fat, and that too preferably mono and polyunsaturated fatty acids. And the carbohydrates should be complex, it should not be refined, and sugary desserts should be avoided, and sugary drinks should be avoided, स्पेसिफिकली दोज पकौड़ा एंड ऑल दो शरबत जो हम पीते हैं, पकौड़ियाँ जो होती हैं, उसको अवॉइड करना चाहिए। चने बहुत अच्छी चीज़ हैं, 2-3 खजूर भी अफ्तार के टाइम पे बहुत अच्छी चीज़ है। फ्रूट्स जो है बहुत अच्छा डिज़र्ट्स हैं, उसको ले सकते हैं। हमारे खाने में जो है डेयरी प्रोडक्ट्स भी होना चाहिए। तो ये सारी चीज़ें हमें करना चाहिए, और जो हमारी टोटल एनर्जी रिक्वायरमेंट है उसके हिसाब से एक चार्ट जो है पेशेंट को जो थोड़ा फ्लेक्सिबल हो, पेशेंट के जो उसके लोकल रिचुअल्स एंड कस्टम्स और जो पेशेंट की ईटिंग हैबिट्स है, उसी को मॉडिफाई करके हमें एक ऐसा बैलेंस चार्ट देना है जिससे कि पेशेंट फॉलो कर सके। एक्सरसाइज भी एक बहुत इंपॉर्टेंट पार्ट होता है। पेशेंट पूछता है मैं प्री रमज़ान विजिट्स में एक्सरसाइज से क्या करें, तो उसमें एक चीज़ बहुत इंपॉर्टेंट है कि इंटेंसिव एक्सरसाइज दैट टू ड्यूरिंग इवनिंग, वो पेशेंट को अवॉइड करना चाहिए, क्योंकि उस वक्त हाइपोग्लाइसीमिया के चांसेस बहुत होते हैं। एंड जो रूटीन एक्सरसाइज या रूटीन डेली एक्टिविटीज़ है वो पेशेंट को करते रहना चाहिए। और जो पेशेंट जो है एक अलग से प्रेयर होती है जिसको कि हम तरावी कहते हैं, तो तरावी, इफ समवन इज परफॉर्मिंग तरावी, so it is taken as the moderate amount of activity, because patient has to many times they have to kneel, they have to bow down, kneeling is there, rising in there, then it should be considered as their daily exercise activities. So अगर ये और ये काफ़ी लंबी होती है, many times it is around you can say 60 to 90 minutes can be there. So अगर कोई आदमी तरावी पढ़ रहा है तो फिर उसको अलग से कुछ एक्सरसाइज करने की ज़रूरत नहीं है। एंड दोज हु आर quite enthusiastic about their exercise, in that situation we can tell them that you can do it after the you can say iftar, or you can do someone wants to walk, then you can have a stroll after the suhoor, where the even the you can say the weather is very pleasant and roads are empty, it's safe to walk at the time, so they can walk and they can do their physical activity at that time also. And there is also interesting, individuals are more likely to achieve their HbA1c targets and reduce body weight when more nightly prayers are performed. So this has also been seen, and we can encourage the patient that you should do that. If you want to do, then it would going to have a beneficial effect on you. So medical adjustment, medicine adjustment is an important thing which every patient needs to discuss with their you can say healthcare provider. I think they should be taken in some of the you can say lectures, and because this is a very important topic and which needs to be discussed. The sulfonylurea, they need to be reduced, and metformin they can be taken at, in the same dose. And if the doses are different, then the larger dose should be taken at the time of iftar and the smaller dose at the time of suhoor. And DP4 inhibitor, they can also be taken as usual during Ramadan period. And those who are SGLT2 inhibitors, then the same dose can be continued and it can be taken at the time of iftar only. And those who are on multiple daily dose of insulin, in that situation, ideally the patient should not be fasting. But if they insist on fasting, in that situation, the you can say the morning dose shift towards to the prior to iftar, and the night time evening dose shift to the prior to the suhoor, and that dose needs to be reduced, and the basal dose can be kept at same, or it can be reduced by 10 to 20%. And the lunchtime insulin can be skipped, and that should be skipped because patient is not taking lunch, so that insulin needs to be skipped. And those who are on sulfonylureas, if they are on older generation sulfonylurea, though it is not common, but still many patients they are taking glibenclamide. So in that situation, we need to change their sulfonylurea to newer generation sulfonylurea. And glycoside has shown some amount of less propensity for hypoglycemia as compared to the glimepiride. And the dose of sulfonylurea is usually reduced to the half in those patients who are having good glycemic control prior to Ramadan. So this we have already discussed. When to break fast, if the anytime patient check blood glucose and it is between 70 to 90, it is less than 70. In that situation, it should break the fast, and if it is more than 300, then also the fast should be broken. And the sign and symptoms of hypoglycemia and hyperglycemia should be very well explained to the patient that these are the problems. If you feel these kind of things, keep trembling, sweating, palpitation, hunger, or you can say confusion, altered mental status, of the patient is having severe kind of headache. And headache is also quite common in the initial days of Ramadan because of the caffeine withdrawal in those patients who are taking quite used to take multiple cups of coffee or tea. So they don't take coffee and tea, so their body takes some time to adjust. So a headache can be there. So if headache patient is having a headache, so at the time blood sugar should be checked, and if it is normal, it means that most likely in the initial stage it is because of the caffeine withdrawal. And hyperglycemia, we know extreme thirst, hunger, frequent urination, extreme weakness. So all that kind of thing, if it is there, then blood sugar should be checked. So technology, this definitely has revolutionized the things because the use of CGM and all those kind of things. So if we have a team where we can do these kind of things, then definitely that is also going to be of some help to our patient. But for that, we need a good amount of, you can say, understanding by the patient, and also we need to have a good team for that. So delivering online educational courses via smartphone and applications, short message services, like SMS text. So all these can be done to see their compliance, to ensure their compliance, and to see if they have any problems. So we can address those kind of problems by this SMS and all those kind of things. CGM is also definitely CGM along with the insulin pumps and all those things. They can be of some help, specifically in those patients who are having type 1 diabetes or those who are having brittle kind of diabetes. There, it has been shown that they are quite effective in preventing hypoglycemia and blood sugar fluctuations. So that can be used if patient can afford that. The only problem is that it is quite costly, so everyone cannot afford. So, but those who can afford, they can be advised that if you are taking multiple daily dose of injection and if you want to switch to a pump, that can be done because it has been seen that they are quite good at preventing hypoglycemia. So role of educators in pre-Ramadan diabetes education. So we know that education is of paramount importance in all chronic disease because their patient has to take their own care. So self-care is there. So if the self-care is there, then it's very important that they should understand what is going to happen. So in that situation, we need good educators who themselves are very well versed with these kind of things, and so that they should provide structured and you can say helpful guidance to the patient. And the things which needs to be emphasized is that how often they should monitor their blood glucose, and what is the importance for looking out of low blood glucose, and how to alter the dose and timing, Food and diet intake is also very important, and importance of avoiding the strenuous physical activity. And if the patient want to exercise, then what should be the time and what should be the intensity, all those things should be told by the educators. So because if the patient understand the risk and know how to manage them, then definitely it is going to have a good effect on the overall outcome during the Ramzan. So these are the positive impacts which can be achieved because of Ramadan focused education, that we need. We can have good, greater glycemic control, better self monitoring glucose and treatment and management, sustained motivation to adhering to the guidance, and greater empowerment to fast during Ramadan, specifically if the one during one Ramadan patient has fasted safely. That gives them immense amount of satisfaction and confidence that okay, they can do that, and during next Ramadan that thing will be quite helpful. So these are the take home points, that pre-Ramadan education is the key component of safe fasting during Ramadan for those people who are having diabetes. Pre-Ramadan educational program should target not only with the people with diabetes but also the healthcare providers, because things are not so many things are not so clear. So we need to make those things clear to the health providers first and to the educators, so that there should be no, you say, misinformation or lack of information or lack of communication between the patient and the healthcare providers, which includes both the educators, the nurses, the other staffs, as well as the doctors. And general public awareness is also very important, because overall, if the society is supportive to the patient, then definitely patient is quite confident, and that gives some amount of, you can say, confidence to the patient and assurance to the patient that okay, what we are doing is good. And those misconceptions, if it can be removed from the general public, that also helps very much in management of patients with diabetes during Ramadan. Like if you are checking your blood glucose, that is not going to invalidate your fast. And studies have shown clear benefits of educational program on glycemic control, weight loss, improving the risk of hypoglycemia, even in very high risk individuals. One of the largest study, that EPIDAR study, they have shown that almost 60% patient of type 1 diabetes, they have kept fasted safely during Ramadan. So that is the power of education and empowering our patient for taking decisions depending upon their blood glucose and depending on their health status. The positive outcomes of these programs may also be extended beyond the month of Ramadan fasting. For example, if someone has lost weight, so we can motivate the patient that you have lost weight now. You if you want, you can sustain that amount of weight loss, so it will be very good for you. And because during Ramadan, patient, they don't eat, and those patients who are smoking, say though, if you can live without smoking for 16 hours, so what prevents you for living without smoking for next 8 hours? So that kind of, you can say, positive motivation can be of some help. That's all. Thank you very much for your kind attention.
Thank you, Dr. Hamid. A wonderful talk, very comprehensive. We are joined by Dr. Nasira Begum, Dr. Ali Nazakat, Dr. Anshul Singhai from Bhilai in Chhattisgarh, and lots of questions for you. Uh, Dr. Gauri Shankar says, apart from risk stratification, we have to learn about dose adjustment, and we will be doing that next week. But a few questions, and we'll take them in no particular order. But pregabalin, if a patient is on pregabalin prior to Ramzan, does the patient need to change the dose during fasting?
No, I don't think that this pregabalin does not need any kind of change during Ramzan. Only thing is that at what time whether they should take it at bedtime or when they can take it even after suhoor, because most of the people, they had to have a nap after taking suhoor, because most of the time the patient is able to sleep just 2 to 3 hours prior to suhoor. So in that situation, if the sedation is much more, so and the patient is not able to wake up and do all the activities during the Sehri time, in that situation, we can tell the patient that you should not take it during night. You can take after taking Sehri. Once you are going to bed, at that time you can take the drug. Otherwise, dose does not require any kind of change during Ramzan.
And
Your
patients who take
opinion, sir?
I agree with you fully. You ask the
Okay.
patient about his or her lifestyle and their job. Now, if the person happens to be a doctor or a bus driver, then taking pregabalin at suhoor time will not be a good idea. But if the person is maybe retired, a homemaker, stays at home, has taken an off for 1 month, he is lucky that his head of department has given him chutti for 1 month, then suhoor will be a good idea. So you have to take the history.
Yes.
Uh, Another question is atorvastatin and aspirin. So this particular patient has been taking aspirin atorvastatin at noon time. So ideally, what is the best time to give statin? And otherwise, also in Ramzan, what is the best time to give statin?
Conventionally, we give statin at the bedtime, so that times I think we can keep the same during Ramzan also. That's not an issue.
Yeah.
I think it's very clear that we can give this antiplatelets and this atorvastatin many times. They are combination drugs, so they can patient can take it safely at the bedtime. It's not an issue.
Also, Dr. Vinayak Sharma has joined us. And another question is, suppose a patient is taking any particular antihypertensive. In routine practice, what do you do in Aligarh? Do you reduce the antihypertensive dose during Ramzan? Do you reduce the diuretic dose during Ramzan? Do you change the time of diuretic usage during Ramzan? Routinely, what would you do for the average patient in your OPD?
Uh, Most of the time we don't change the drugs, but for example, this year the things might be somewhat different because we see most of the time the dose of antihypertensive they need some amount of you can say intensification during the months winter months, and now the winters are going, the summers are coming. On the top of that, we are having Ramzan. So one thing is that monitoring is very important. If the patient is having that kind of thing, patient is having you can say postural giddiness and all those kind of things. In that situation, patient can check their blood, their BP, blood pressure, and if it is coming on the lower side, then definitely they need down titration. But most of the time, if the patient what the dose patient was taking during summers, and they can continue on the same dose with the education that you should if you have any kind of problem, postural giddiness and all those kind of things, increased thrust, in that situation you should check your blood, along with blood glucose you should check your blood pressure also. And if it is on the lower side, for example, it is less than systolic is going less than 110, in that situation down titration might be needed in that patient. But most of the time we keep the dose same, and we give it most of the time after the iftar, because after suhoor we don't want to give this diuretics, because that will hamper their you can say sleep also, and the risk of dehydration will also be quite high, because if they have taken and after that they have stopped taking fluids. So most of the time we give it at the time of iftar.
Let us just put this in perspective for people who are listening to us from across the world. In South India, temperatures usually remain the same 12 months in a year. So, usually there is no change in antihypertensive dose based upon season. In North and Northwest India, however, we have extremely cold winter and extremely hot summer. There is a lot of change, and whatever the books write, that is separate. But virtually every physician will tell you that we have to reduce the dose of diuretics, and sometimes we have to reduce the dose of antihypertensives during summer. So, what Dr. Hamid Ashraf is saying is if at all you are going to make a change in the coming weeks, it will be because of the change in temperature, because summer is approaching. It will not be because of Ramzan specifically. Second thing is that if you are giving a diuretic before Ramzan, you give it at breakfast most of the time. So now also you will keep on giving at breakfast, which happens to be iftar, which happens to be at night. So you just keep the diuretic along with the breakfast. Sir, more questions. And now this is a 52-year-old gentleman who is on a very atypical regimen. So the regimen is like that, so that we cannot change. Now the question is, what do we do during Ramzan? He is on insulin premix 30/70, 20 units in the morning and 20 units at dinner, plus metformin 500 milligram BD, plus glimepiride 2 milligram BD. So it is atypical because premixed and glimepiride are being given
Yes.
together. But that is what the patient is on, and he seems to be doing well. How do we change the dose when Ramzan starts?
Yeah, in this particular patient, so one of the things which we need to ask is that what is the history of hypoglycemia is there or not. If the history of hypoglycemia is there in recent past, in that situation, what I would do in this patient is that I would stop the glimepiride first thing, which I would do, and after that some amount of reduction. Usually what we say that around 50% reduction in the evening dose, which should be given at the time of sehri. So in this particular patient, because I am removing glimepiride, so I may not reduce it by 50%, but by, for example, if the patient is taking 20 units, I will make it 15 units. But the thing which would be very important in this patient, because we need to tell that you need, you can say, good amount of monitoring blood glucose, because whatever the changes we are going to make, we don't know exactly what is going to be the response of that thing, because sulfonylurea ideally we should avoid giving with insulin. That to premix insulin itself has a very high risk of hypoglycemia when we compare it with the basal insulin or multiple daily dose of insulin. So monitoring of this patient would be of paramount importance. So the thing is that that's why it is important to have a pre-Ramzan checkup at least 6 to 8 weeks before Ramzan. So if you want to take the sulfonylurea out from the regimen, so we should know, because what we have seen personally, that if you take out the sulfonylurea, results can be very erratic kind of things can happen. If you are removing sulfonylurea, the blood glucose can go very high, and many times there are no changes at all. So we don't know how much sulfonylurea is working in this patient. In ideal situation, pre-Ramzan education and all those kind of assessment, if it has been done around 1.5 to 2 months prior to the Ramzan, in that situation, it would give us, you can say, some amount of confidence that what should we do with this patient. Otherwise, if the patient don't have that much of time, that's what we should do, that I have discussed already, that I would like to take the glimepiride out, and more amount of monitoring should be done in this patient.
I would agree with the Dr. Hamid Ashraf, with Professor Ashraf. So something like premix 15 at the suhoor meal, 20 at the iftar meal, continue that and stop glimepiride. But do keep on monitoring and remind your patient that checking blood glucose during the non-fasting period is not haram, because nothing is going into the body. If at all some change is occurring, blood is coming out of the body. So the fast will not break if the patient checks his glucose maybe 2 hours after suhoor or maybe around noon time and then before iftar. More questions coming up for you. Sir, usually we say that insulin, premixed insulin, when it is given twice daily, it should be given at 12 hours interval. So now during Ramzan, supposing we give the morning injection at 4 a.m. and then patient takes the evening injection at 7 p.m. So that is a 9-hour gap. So is this safe with modern insulins?
So definitely there's where the modern insulin comes, because if we talk about conventional 30/70, if the patient is taking NPH type of insulin where there is some amount of peak, so definitely chances of hypoglycemia can happen, specifically after taking the suhoor meal. For example, if the fasting is going beyond, you can say around 12 hours, 10 hours after that, the chances of hypoglycemia is quite high. So in that situation, we might need more amount of data, but theoretically speaking, if we are having co-formulation, for example, someone is taking SPART along with the degludec, which has no peak, in that situation, I don't think it is going to have, theoretically speaking, they should not have any kind of problem if the interval is changed, because the parental insulin which we are giving in the co-formulation will take care of the postprandial hyperglycemia which is happening, and the basal insulin, which does not have any kind of peak, will be slightly better if we compare NPH with the you can say newer kind of insulin. So that's definitely a problem, but that's how we have to manage the patient.
Dr. Anshul also says that using the modern analogs, one of the advantages is safety. And during Ramzan, you can try 5S, fast acting injection aspart, or the other analogs. They will be much safer because the peak is shorter. And if you use premixed insulin, if you use the older ones, bovine porcine, then there used to be a lot of hypoglycemia. With the modern human insulins that are available in Pakistan and India, things are fine. But if you can use premixed analogs, that will be safer. We also welcome and salam and adab to Dr. Meena Minam, who is watching from Pakistan. So, Dr. Ashraf, thank you from Pakistan as well for a beautiful talk.
Thank you, ma'am.
One tough question coming from Chhattisgarh. This is any experience with imeglamin in Ramzan?
Personally, speaking, I don't have because it has just been become available
Mm,
just few weeks back or few months
months
back.
ago.
So even in non-Ramadan period, I don't have that much of experience. So I don't have any personal kind of experience with imiglamin. But if we go to the theory, then definitely, if we can say that something like metformin, there are less chances of hypoglycemia and all those kind of things.
It
So
is
this should be safe, but prior to exploiting anything, definitely hard data is needed. Maybe within 1 or 2 years, for example, in last few years, we have good amount of data with the SGLT2 inhibitors, and we are also collecting our data of SGLT2 inhibitors from this year in Ramadan. So definitely it will take some time, but theoretically speaking, I think there should not be a problem. And I would also like to know, sir, your opinion on this.
we have a lot of experience now with imeglimin, and theoretically speaking, there should be no hypo. But some patients respond so beautifully to it. So, just few things I would like to say are, if your patient tells you that he or she is going to fast, please do not start any new drug from tomorrow. Only 10 days are left. So whatever new drug we had to start, we should have started last month before Shaban began in Rajab. So Shaban is not a time for experimentation. So don't start any new drug. Now, if your patient is doing very well on imeglimin plus whatever other drugs, we will continue the same. You will reduce the insulin, you will reduce the sulfonylurea. If, however, your patient continues to have hypo, and I see this comment coming in again from Dr. Anshul, I am witnessing reduction in insulin dosage once patient is put on imeglimin. Yes, Anshul, I am also experiencing that. We are not able to figure out which patient is going to respond dramatically and who is going to respond just a little bit. So, if you feel that hypo is occurring now, and now Ramzan is going to start after 10 days, you can stop the morning dose of imeglimin, 500 or 1000, whatever you are giving, continue the night dose, but keep on reminding your patient that monitoring is of utmost importance. Dr. Singhai also reminds us that no new drugs to be started now over the next 10 days. Tell the patient, whatever gear गाड़ी जिस gear में चल रही है, let me shift to Urdu and to Hindi. जिस भी gear में गाड़ी चल रही है, ठीक है. Now whatever changes we will do after Eid. And also, if the patient is not well controlled, if there is a lot of glycemic variability, hypo, hyper, as it is, patient is at high risk. So we will be requesting the patient not to fast. There is one more question, and this is again a patient, middle-aged gentleman, metformin 500 BD, vildagliptin 50 BD, glimepiride 1 BD. So, what changes will we make in the dosage from 10 days from now? He is on triple oral therapy: glimepiride,
Yeah,
vildagliptin, metformin.
yeah, metformin and vildagliptin we will keep same. If the patient is taking combination of metformin and vildagliptin, so 500 plus 50 at after the iftar, and 500 plus 50 at sehri. And glimepiride, I would like to reduce the dose to once daily only. If the patient was taking twice, 1 milligram twice daily, so I would make that 1 milligram once daily, and that too with, at the time of iftar.
Iftar. So, thank you for that answer, Professor Ashraf. We've got so many questions today. The best part is that it makes my job much easier. Next week, I will be speaking about dose adjustment, but we've already got
Yes,
all the
yes.
answers from Dr. Hamid. So, thank you, Dr. Hamid. And we, Anshul and Dr. Gauri Shankar don't laugh at me, but you remember this Indian advertisement, Har ek friend zaruri hota hai. So, you see, that's why Dr. Hamid is there, because he answered all the difficult questions for me. We'd also like to thank Meena Minamji for joining us. Dr. Nasira Begum joined us, and Ali Nazakit ji, and also Vinayak Sharma. It's good that we are all together. We are able to revise our subject, understand it in a very nice and a very friendly, fun-filled manner. Dr. Vinay Desai says, Are sir, first things first, tell us what imeglimin is. So could you please do that, Dr. Hamid, before we conclude today?
सर मेरे ख्याल में आप ही बता दें तो ज़्यादा अच्छा रहेगा because personally we have just started it around 1-2 weeks because and the person
It is,
from they came quite late, it was not available. I think you have good experience, तो सर
it
आप ही
is
बता
a
दीजिए.
new drug, and the beauty is, Dr. Anshul points out that thanks to modern drugs, thanks to modern medicines, we are able to help our patients fulfill their religious obligations. I agree with you, Anshul, 101%. The drugs that we had earlier, the glucose monitoring systems that we had were not so well developed 20-25 years ago. So most of the time we had to tell our patients that they cannot fast. You have to have a 3 meal pattern, 6 meal pattern with whatever you are taking. And now, thanks to these new drugs, new technology, new monitoring, we are able to do it. And it is, how do I put it? Everybody earns merit when you are able to share knowledge with each other. This question about imeglamin, let me take. It is an oxidative phosphorylation inhibitor or metabolizer, modulator. It works at the level of the mitochondria. Now, what do the mitochondria do? You have got mitochondria in the beta cells. The mitochondria give energy to the beta cells, and there is first phase and second phase secretion of insulin. So, this imeglamin acts as an insulin secretagogue. What extra it has over glimepiride is that it increases the first phase secretion of insulin also. Whatever preformed insulin is there is secreted very fast because the mitochondria become fast. So, it is a secretagogue. At the same time, it is a sensitizer, especially at the level of the skeletal muscle. So you have insulin receptors in the liver, skeletal muscle, and adipose tissue. It is a sensitizer at the level of the liver and the skeletal muscle, especially skeletal muscle. So what it does is it increases the efficiency of the mitochondria to handle whatever insulin is there. So it has dual effect, secretagogue plus sensitizer. Within secretagogue, it improves the first phase secretion also. So somebody has 1 hour high postprandial, 1 hour postprandial hyperglycemia, this drug will act. It may be considered later on, though the research is not very strong right now, as an exercise mimetic. I go to exercise, I improve the mitochondrial efficiency of my skeletal muscles. But I cannot exercise now because I have got osteoarthritis. Maybe imeglamin will help. It will be an exercise mimetic. So these are two ways in which the drug acts. It works very well in some patients and is actually able to have a very strong insulin sparing effect. In others, it works like a little bit like metformin plus and is able to bring down HbA1c by 1%. So a good drug to use in patients, you can prescribe now in patients who are not fasting. And in those who want to fast, maybe it would be a good idea to say after Eid we can try. Thank you, Dr. Hamid, from Dr. Gajanang Sanap as well, and from Dr. Pratik. From my side, I would also like to thank you. We started out as a 30 minutes talk and it's 55 minutes already. So thank you once again. Thank you for answering the questions on dose adjustment as well. And thank you for being part of the Diabetes Essentials family. I'd like to have final comments from Dr. Hamid before we hand over to Team FDC for their vote of thanks. Dr. Hamid, please.
Thank you everyone for nice, you can say, very good participation. We have a lot of questions. Thank you organizers, and thank you sir for I think difficult questions has already been shared by you also in a good manner. One thing which I would like to give the take home message is that it's very important that we should start the preparation quite early. Risk stratification, that too objective. Yesterday I was in a meeting, so there was some people who were saying that many times there is some legal point of thing, and along with that there is some religious point of thing is also there. So if we want to be an objective kind of thing, then definitely this IDF risk stratification score is there. So we can tell that we can fulfill our responsibility by telling that that this is the thing which has been validated by the Mufti and all those kind of things. The religious scholars has also, you can say, they have also endorsed the thing which I am telling you, and this is up to you what you should do now, because informed and shared decision needs to be taken depending upon the risk. And apart from that, the education regarding that frequent monitoring of blood glucose, specifically those patients who are moderate risk or high risk and they are insisting on fast, and we should tell them that if you are checking blood glucose frequently, that is not going to hamper your fast, that is not going to invalidate your fast, and it will help you in fasting, keeping your fast safely. That's all. Thank you very much.
Thank you, Dr. Hamid. Team FDC.
Thank you, sir. I think, sir, we have already started getting the momentum in the 2 out of 3 the sessions which you have designed, and you can see the questions which have been coming today. And with the 2 sessions concluded today, I think, sir, 50-60% of the knowledge have been well accepted by our viewers, and the last dose adjustments and the medications will be taken by you in the next session just before the Ramjan, which completely, I would say, will be satisfactory from our end that during the Ranjan education period, we could deliver these 2 important lectures. And exactly just before the Ramadan, we can actually help the doctors to adjust the doses and the medicines. With this, I sincerely thank Dr. Hamid Asraf for being with us, because I know it's been very wonderful to get the doctors from all across the India, because this has been designed such a way by Dr. Sanjay Kala that we got last time from the west, now from the north, because the temperatures are different, durations are different, meal patterns are different, and and we have got subject experts from across India. With this, I sincerely thank Dr. Sanjay Kalra for once again designing such a wonderful sessions just before Ramadan. Thank you, sir. Thank you, Dr. Hamid. With this, we say good night and Jai Hind.
Okay.
Jai Hind.
Jai Hind.